So 65-year-old woman for screening, asymptomatic. You can go to the next slide. Here was her initial from the CC on the right side, and don't strain your eyes. It's going to be very difficult to see the group calcifications here that we're discussing, but on the next slides we'll help you out and show you the detections, which, when you're using the suite of algorithms, that obviously is the initial point of use, is the detection, showing you where to look, helping you from missing something that's subtle. So the detection is where it starts first. The next slide. So we have a detection here on the CC. Again, you're not going to see it on these images. I'll show them to you when we get to the end of the case. There's some calcifications there. And this was a lesion score of 41 and a case score of 57. And I want to just expand a little bit on the scores, especially for people who aren't used to having scores on their mammograms and knowing what to do with them. Just for background, across the board, usually we're going to see about 85% of all the cases are going to be less than 60. So 15%, and I'm talking about case score here, 15% of the total that you see typically is going to have a case score over 60. So when you're using a score as a clinical decision tool, what you need to realize is that by far and away most of your scores overall are going to be low. So anything above 60 starts to really raise suspicion, but moderate scores like AXA was showing as a clinical decision tool often are not really definitive as to what to do next. So with this case, with a case score 57, I know AXA had some where the scores were in the 40s or even lower. What that's saying is the algorithm successfully performed the detection, which is step number one, which is obviously super useful when you have a sensitivity in the low 90s for detection. But as a clinical decision tool, those intermediate scores are telling you the algorithm's not really coming down one way or another on whether it's benign or malignant. And so at that point, when you're looking at these images, you're wanting another metric, and that's really where the risk comes in. You can go to the next slide, please. And again, MLO view, you're not going to see the calcifications. Can you go to the next one? So again, we have these intermediate, we have one detection, these intermediate scores and an elevated risk score, and you can go to the next one. So we did the diagnostics, and again, we had a metric here, which was the elevated risk score that was really pushing us in that direction. And as Axel pointed out on multiple cases, when you get to this point in the review, you're kind of looking for something else that can help you make your decision. And with the risk score being high, that's what really will trigger you going to the next step. And again, Michael's recent paper was super informative. They're showing people with a high risk to have a 20% increased chance of getting cancer compared to non-high risk patients. It's very heavily weighted on age. So when you get a high score in the lower ages, that significance increases. So the point there is, 70-year-olds, you're going to see more of your high risk scores in that group, and the younger patients not so much. So when you do get a risk score in somebody younger, that presumably is even more relevant. So we can go to the next slide here. So again, a magnification view, we have grouped pleomorphic calcifications here. We're able to see them a little better than on the first images that I showed you. And then the next slide, please. And here's our post-biopsy specimen showing the calcifications finally, so where you can see them pretty well. And we can go to the next slide. So moderate case and lesion scores, but again, the high risk score was what really motivated us to go on to the next step and pursue a biopsy, very similar to the decision path that Axel demonstrated at his facility. And again, just to mention Michael's paper, 20 times likely to have malignancy when you're a high risk. The total population that in his recent paper with a high risk score was 14% of the group versus Tyler Cusick 8, which is about 12%. Average length of follow-up time for his paper was a year. And I think one of the really easy to remember statistics here is that with their recent paper, they captured 59% of the eventual cancers in the high risk group. That would compare to the calculated simulated Tyler Cusick rate for that same group, which would have been about 24%. So in the time interval of the study, which average follow-up was 1 year, high risk with profound, as demonstrated by Michael's paper, identified 59% of the patients that were eventually malignant versus Tyler Cusick, which would have been 24. So we're talking about a 2.4 times improvement in that metric. And again, when the patient does come back as a high risk score, they have a 20 times the chance of having a malignancy. So again, it's definitely it goes into the workflow as at this point mostly the third step in how I use these. So it's detection, then it's the scores, the lesion, and the case scores, and then the final metric that we use is the risk score.